Good afternoon, everyone. My name is Maria. Many of you know me as Teng Santiago from Cohen Children's Medical Center in New York. On behalf of my web committee co-chairs, Mitzi Go and Annie Coates, Anne is also our current PEDS web committee co-director with Christina Gaido. We would all like to thank you and welcome you to our Journal Club webinar today. We are honored to have our presenter and panelists today. Our presenter is Dr. Professor Armand Mekontso Dessap, who has been chief of the Medical Intensive Care Unit at Mondor University Hospital since 2015, and he's the director of CARMAS, which is the Cardiovascular and Respiratory Manifestations of Acute Lung Injury and Sepsis Research Group at the Université Paris Creteil, which focuses on acute respiratory and circulatory failure. He will be discussing the article, The Comparison of Prophylactic and Therapeutic Doses of Anticoagulation for Acute Chest Syndrome in Sickle Cell Disease, published in the American Journal of Respiratory and Critical Care Medicine, April 2025. We are joined by a panel of both adult and pediatric experts, Dr. Elizabeth Klings, who's the director of the Center of Excellence in Sickle Cell Disease and director of the Pulmonary Hypertension Program at Boston University, Dr. Barbara Levarge, associate director of the Pulmonary Hypertension Program at the University of North Carolina, Dr. Shaina Marisa Willen, pediatric hematologist and pediatric pulmonologist who heads the Comprehensive Sickle Cell Clinic at UC Davis Medical Center, Dr. Benjamin Kopp, who's the director of the Pulmonary Sickle Cell Program at Emory University, and Dr. Say Si from the Division of Pediatric Hematology at the Barbara Bush Children's Hospital. Dr. Ann Coates from the Barbara Bush Children's Hospital in Maine will be co-moderating this session with me. We will ask Professor Dessap to give a 20 or 25-minute presentation of the article, after which I will ask our panelists to give their comments and maybe ask some questions. Annie will then open up the floor for discussion and questions from the audience. So we are asking you to please write your questions in the chat, and Annie will field the questions to our presenter and panelists for their response. And if you'd like to comment or ask a question out loud, please raise your hand and we will unmute you. And so we're really looking forward to a very interesting discussion of, as Dr. Klings says, a very provocative article. And so without any further delay, Professor Dessap, the floor is yours.
Thank you very much for the invitation and for the introduction. So we are going to discuss this article. I would like to spend some time for the background, not to explain to all those experts what is sickle cell disease. You all know that it's a mutation on the beta globin gene leading mainly to vaso-occlusion due to the polymerization of HBS. But the clinical manifestations are very wide, and among them, those related to vaso-occlusive crisis, acute chest syndrome, and osteonecrosis are thought to be mainly due to this vaso-occlusion phenomenon. So the article focuses on acute chest syndrome, which is a very old entity, and it's important to go back to the first definition. For example, this one proposed by Sharash in this article, where the idea was that a patient had a feature looking like pneumonia, but he found no pathogen. And the main hypothesis for this clinical presentation was pulmonary infection. But it's very hard to diagnose pulmonary infection when it is similar to vaso-occlusion of microcapillaries in the lung, because there is no imaging technique to do that. That's probably why the common definition of ACS relies only on criteria, a clinical sign, as you know, and a pulmonary infiltrate, which is in conservative definitions, a consolidation somewhat close to the infarction hypothesis, because We want it to be at least segmental and not to be an atelectasis. But in clinical practice, it's not easy to rely only on chest X-ray to do that. And we have been developing long ultrasound for the diagnosis also. For example, in this study in adults, we compared long ultrasound here in black to chest X-ray in green using CT scan as the reference. And you can see that the agreement of long ultrasound was better than that of chest X-ray. And that if we talk in terms of sensitivity or specificity, especially in the posterior inferior regions, which are those more prone to acute chest syndrome, the sensitivity of long ultrasound is better. So for the diagnosis, there are great tools for that. Acute chest syndrome is one of the main indication for ICU admission in the adult. You can see here in this series in France that more than half of admissions were due to acute chest syndrome, and it is still associated with a worse prognosis in this setting because the majority of deaths in adult, at least, are due to acute chest syndrome in many series. And on top of this immediate prognosis, which is worse, the delayed prognosis is also affected because in the lifetime, a patient having acute chest syndrome will have a long-term mortality higher than a patient without it. So it's important to understand the pathophysiology of acute chest, and the first phenomenon ascribable to acute chest syndrome was not the vaso-occlusions suspected by Sharash, but fat embolism, with the reasoning that following a severe vaso-occlusive crisis, lipids can be released in the circulation and lead to lung fat embolism, and this was demonstrated with spatial colorations of sputum or long expectorations. For example, here, oil or red coloration showing that macrophages had fat content, and they were detected in nearly half of ACS patients. And this fat embolism can also affect the systemic circulation, especially in patients with right-left shunts like patent foramen ovale. This is an image of MRI with fat embolism within the brain in SWI phase mapping. So there is a clear association between bone marrow necrosis, fat embolism, and ACS. As demonstrated here, you see an overlap between those clinical presentations. And the second actor is the vaso-occlusion that was suspected by Sharash, but for many years it was impossible to demonstrate because we cannot image lung capillaries. But we did a study in 2011 with CT scans and found that 17% of patients with ACS had macrovascular occlusions in pulmonary vessels, and that were often in regions of consolidations. Our first question was, is it fat? So we measured the Hounsfield density of those material and found that it was higher than the expected density of a material that would be mainly fat. So it was cryoric, and this is in line with autopsy studies where on top of fat material here in black, we can find also fibrinochloric material in the lung vasculature of these patients with a prevalence even higher than fat material. The second question we had was, is it regular thromboembolic disease? So we compared our series to classical thromboembolic disease. You know that in classical embolic disease, you have 45% of DVT when you have a pulmonary embolism, like in this series of Girard. But in our series, there was a striking underrepresentation of DVTs. We had only one DVT, but which was below the knee, so that we couldn't count. The second aspect was the distribution of the thrombi. In classical thromboembolic disease, the majority of thrombi are proximal, lobar or truncular, like in the series here by Regini. But in our series, the vast majority of thrombi were peripheral. They were subsegmental or segmental. Only 10% of them were proximal. So we raised the hypothesis that we were looking at just a small part of the iceberg, the 17% of patients with thrombosis within the large elastic arteries, but that maybe the vast majority of patients had some thrombosis within the capillaries, and the extension of that thrombosis within the large arteries was possible in a minority of patients. So the first step was to work on a score to detect patients likely to have a positive CT scan. So we developed this PATAX clinical score with these four parameters, especially thrombocytosis. You see that the higher the score, the higher the likelihood to have a positive CT scan in terms of pulmonary artery thrombosis. And this score is better than the classical scores used, for example, in the emergency department, like the revised Geneva score, to select patients for the CT scan. The prognosis of acute chest syndrome is mainly driven, in our experience, by acute pulmonary hypertension during acute chest syndrome. In this study we did in 2008, you see a striking rise in pulmonary artery pressures during the episode that is associated with mortality. So it's probably driven by vasoocclusion, by fat, or by phenylchloride material we discussed earlier, but it can also be driven by vasoconstriction, because you see that this hypertension is also seen during vasoocclusive crisis without acute chest syndrome. So probably the hemolysis with the liberation of free hemoglobin and free heme can scavenge nitric oxide and lead to vasoconstriction. Oh, sorry, I will go back. So when we look at the prognostic factors of acute chest syndrome, we have this pulmonary hypertension we already discussed about. And in our clinical practice, we think that it's one of the drivers of multi-organ failures. For example, if you look at the determinants of acute kidney injury during acute chest syndrome, you see that patients with acute kidney injury, here in black, are more prone to have higher values of systolic pulmonary artery pressure, a higher prevalence of cor pulmonale during acute chest syndrome. So for the management of acute chest syndrome, it's important to tackle lung vascular dysfunction, which has two possible drivers, the constriction and the occlusion. We did a study for the constriction using high doses of nitric oxide at 80 ppm, and we were not able to find an improvement in the composite outcome we used in the study, but we had a signal in the most severe patients, those with hypoxemia here, that may benefit from this therapy. And the other question is the question of the occlusion. As we saw, we can use the PATAX score to select patients for a CTPA, and if we find thrombosis within the large elastic arteries, we propose at now a therapeutic anticoagulation for 3 months, in analogy to the classical thromboembolic disease. But if the CTPA is negative, we have that question of microvascular thrombosis within the lung capillaries. That's why we designed the task study with the following hypothesis. Therapeutic anticoagulation during acute chest syndrome could decrease disease duration compared to prophylactic anticoagulation through the resolution of microvascular pulmonary thrombotic phenomena. So we performed the study in 12 hospitals in France, with the primary efficacy outcome being the time to ACS resolution that we defined by the joint improvement of the criteria associated with acute chest, which are fever, chest pain, dyspnea, and hypoxemia. And we also have a safety outcome, which was major bleeding using international definitions, but from which we adapted to ACS, because in those definitions, you have transfusions, which is routine during a vaso-occlusive crisis. So we didn't take this into account. We have many secondary outcomes, including those of parenteral opioids, but also non-major bleeding, catecholamine ventilation, ICU admission. And we also looked at rehospitalization at 6 months in these patients. So we included adult patients with major sickle cell disease with the classical definition of ACS, which is a clinical symptom and a new pulmonary infiltrate. We had many exclusion criteria. The aim here was to select a population with a low risk of bleeding. So we didn't include patients with low creatinine clearance. We didn't include extreme weights. We didn't include patients with contraindications to therapeutic anticoagulations or with a high risk of bleeding, like Moya-Moya syndromes, etc. So when the patient was included, he had a CTPA. If the CTPA was positive, the patient was not included in the study, was not randomized, but received therapeutic anticoagulation for 3 months. And if there was no thrombosis, the patient was randomized to prophylactic versus therapeutic for 7 days. We used tinzaparin. We were able to have a double-blind study by using 2 different vials that we merged to inject to the patients. And at the end, some patients had only the prophylactic or only the therapeutic, because in one vial you had water and in the other one you had tinzaparin. So we screened 573 patients. We calculated that we should enroll nearly 200 patients, taking into account those that will have a positive CTPA. There were 22 of them, and the rest could be randomized into prophylactic or therapeutic. So we ended up with nearly 80 patients in each group. The 2 groups were broadly similar in terms of events associated with ACS, symptoms, blood gases, laboratory findings at randomizations. They were also broadly similar in terms of management, like receiving morphine before, the time from ACS diagnostic to randomization, and the transfusion therapies they had before the randomization. In terms of the primary endpoint, there was a difference which was significant in terms of time to ACS resolution that was shorter in the therapeutic group as compared to the prophylactic group. If we reason in terms of days, it was something like going from 6 days to 4.8 days. The overall rate of ACS resolution wasn't modified because it is almost very high in the 2 groups. And our hypothesis was to reduce time to resolution, not to affect the rate of resolution. We found no major bleeding, so the treatment was well tolerated in this study. In terms of the Kaplan-Meier curve, you can see the curves here with a faster probability of resolution in the therapeutic group here in black as compared to the prophylactic group in red. The compliance to the treatment was good. The treatment was planned for 7 days, and you see that the compliance was higher than 75% in most patients in terms of number of days receiving the assigned treatment. We had some subgroup analysis, so you can see in this first plot figure that the primary efficacy outcome is significant in favor of therapeutic in the intention to treat and in the protocol analysis. We used many ways to assess the treatment effect in the intention to treat analysis. And we found no significant interaction for the pre-planned and post-hoc subgroup we looked at in terms of SS genotype, degree of hypoxemia or clinical severity, with very low sample size, for example, for the hypoxemic patients. In terms of secondary endpoints, the cumulative dose of parenteral opioids was significantly reduced in the therapeutic group as compared to the prophylactic group. But all other secondary endpoints, either at hospital discharge or at 6 months, were not different between the two groups, especially the readmissions, either for pulmonary acute chest syndrome, pulmonary arterial thrombosis, or other phenomena. So I just have a few minutes now for the discussion. One point can be whether tenzaparin has a specific effect as compared to other anticoagulants we may use in this setting. We cannot exclude that because we choose tenzaparin based on the fact that this molecule has a specific action on the endothelium with the inhibition of tissue factor, also the modulation of the triphosphate, and disruption of the interaction between endothelium and the red blood cells. The other thing is that the molecule has a very low anti-10A to A ratio. So this balance could place it as more efficient in reducing platelet activation. And we previously saw that one of the factors associated with pulmonary artery thrombosis in the PATAC score are elevated platelets. So at the moment, I cannot say whether using another drug for anticoagulation would have the same efficacy as tenzaparin. The second thing is the finding that it reduces the duration of ACS, but also the consumption of morphine. And there is a previous study using also tenzaparin, which was also a randomized trial, which showed a reduction in the pain severity with tenzaparin. This was a double-blind study also. So we cannot exclude that there is a systemic effect on top of the possible pulmonary effects. So the study has some strengths because the treatment is simple, easy to implement, almost anywhere in the world. But maybe the specific tenzaparin drug won't be available everywhere. This was multi-center, prospective, double-blind. So this is robust in terms of assessment. We did CTPA to all patients. So we only included patients without macrovascular thrombosis, which is a strength. We also carefully selected a population at low risk of bleeding because as the aim was to reduce the duration of ACS, the benefit-risk ratio of the intervention had to be very good. And we found that with this selection, we have no bleeding. So on the clinical ground, it could be found having a good benefit risk to reduce the duration of ACS. The sample size can be seen as modest, 200 patients, but this is a rare disease. And this trial is the largest trial ever conducted in acute chest syndrome, even though the sample size is modest. And the primary endpoint is consistent with the previous mechanism. There are many limitations. The study is not powered for subgroup analysis. We included patients very early in the ACS disease course, so we cannot extrapolate to later stages of the disease after 48 hours. And we had strict exclusion criteria to reduce the risk of bleeding. So this can be only applied to patients with that low risk of bleeding, namely excluding extreme weights, excluding renal failure, excluding hemostatic disorders. So this is not to be applied to the overall population of patients with ACS. And of particular importance, this cannot be extrapolated to children and adolescents, because all I showed you in terms of thrombosis within the pulmonary arteries, hypertension as a risk factor of death during acute chest syndrome, has not been done in children. And it's possible that the pathophysiology of ACS can have particularities in children with probably a major role of infection. So it cannot be extrapolated to that specific population. So in conclusion, we can say that in adults with acute chest syndrome, without pulmonary artery thrombosis on CT scan and at low risk of bleeding, using a therapeutic dose of tinzaparin for 7 days can reduce the time to ACS resolution and reduce the consumption of morphine without increasing the risk of bleeding. So for the practice now in our center, our approach is as follows. When we have a patient with a clinical suspicion of ACS, we do the PATAC score to assess whether we should do a CT scan. So the elements of the score are here. Baseline hemoglobin more than 8.2, no triggering factor for ACS, especially no vaso-occlusive crisis preceding the ACS, no surgery, platelet counts elevated, PCO2 low. If the patient has at least 2 of these criteria, or has a past medical history of pulmonary arterial thrombosis, or is SC, S beta plus, which are more prone to thrombosis, we will do a CTPA. And the CTPA may confirm ACS with pulmonary arterial thrombosis. In this case, the patient will receive 3 months of anticoagulation. If we have ACS but without pulmonary arterial thrombosis, we will screen the patients for contraindication to tinzaparin. Those contraindications are in fact the exclusion criteria of the task trial. And if there is one exclusion criteria, the patient receives prophylactic anticoagulation, which is done by enoxaparin in our center. If there is no contraindication, the patient will receive therapeutic doses of tinzaparin until day 7 or until discharge. So thank you for your attention. I am open to the questions.
Thank you so much, Professor Dessap. I think we will ask our adult colleagues to comment first. I'd like to start with Dr. Klings and then Dr. Levarge. So Liz, did you want to make your comments and maybe ask a couple questions?
Hi, yes, thank you, Armand, for that great presentation and review of your paper and the biology behind this. I think that a couple of comments to sort of clarify things for the group. So, tinzaparin, for the first point, is not actually commercially available in the United States. It was pulled off the market in 2012 or 2013, and this was actually not because of concerns of efficacy or adverse reaction, but because of a contamination of the medication, and so it was removed from the market and then never returned. And so, in the United States, those of us who practice in the United States, we do not have access to this drug. And as Armand commented on, we don't know if the efficacy of between drugs is actually similar in the low molecular weight heparin market. We know that venous thromboembolism and in situ thrombosis are extremely common problems in our adults with sickle cell disease. By the age of 40, 11 to 12% of patients will have had a pulmonary thrombosis or a deep venous thrombosis. And that risk actually increases to 17% in patients who've had 3 or more hospitalizations in the past year. So this is a very common problem. And the biology that you talked about in terms of thrombosis risk in the setting of the intense inflammation that occurs intravascularly in patients with acute chest syndrome absolutely makes sense. This is an important study. It's very provocative, but I have several concerns about this before I would change my practice. And so when I think of our adult population who develops acute chest syndrome, this is a disease of hypoxemia. Your cohort is not a disease of hypoxemia. Approximately 39% of your patients did not have hypoxemia, and only about 15 to 20% of them were actually requiring an ICU admission. So it suggests that your population has a milder form of acute chest syndrome than we typically see in an adult practice. So my question for you is, what do you think, how do you extrapolate your data to what the full spectrum of acute chest syndrome severity?
At the moment, we extrapolate if the patient has no exclusion criteria. But because we didn't have the power to know whether the results are meaningful in the subgroup of hypoxemia, they are too less patients. What we can say is that there is no interaction. So technically, statistically, that means there is no influence of hypoxemia on the effect of treatment. That's why in our ICU, whether the patient is hypoxemic or not, he will receive the treatment as soon as he has no exclusion criteria.
Anything else, Dr. Klings? If so, can we ask Dr. Levarge to
Yeah,
give her comment?
sure. Liz, did you have anything? Sorry, you were muted for a second there.
I'm still muted. Oh, sorry. I did have one more sort of follow-up question. So, ACS resolution is a very interesting endpoint, in that there are factors that sort of impact that may not necessarily be related to therapeutic anticoagulation. Do you have any comment on the fact that there was actually no difference in the outcomes of the need for mechanical ventilation, pressor use, mortality, or ACS recurrence?
Yes, this is a very important point. So usually the patients included in randomized trial during ACS are less severe than the real life patients for many reasons. And one of those are that when the patient comes in and is severe, many physicians are reluctant to include it in any protocol. They just fear that the patients will get worse, and they consider research in that setting as maybe associated with losing a chance or something like that. So this is a recurrent problem we have in all our trials. So I do not expect that in a trial on ACS, an intervention can modify those strong outcomes. For example, for mechanical ventilation, the prevalence is near 10%. If you want to modify that, you really need thousands of patients. That's why we focus on this outcome, which is questionable, but which is objective also. And even the length of stay are very difficult to interpret, for example, in France, because many of those patients can have social problems, and you will end up with some patients who are already with the resolution of the disease but cannot go out. Some others that go out with the disease, not with full resolution. So it's complicated. That's why my opinion is that we should use outcomes that are not very hard, but with a very good benefit risk ratio. So with an intervention that has or a population selected so that the intervention can be relatively safe. So although the benefit can be considered not hard, the benefit risk ratio is favorable.
Okay, so Dr. Levarge, did you want to?
Perfect. Yeah, thank you very much. Thank you, Armand and Nicholas. I was so excited to see the study and kind of this attention in a real sort of organized fashion to anticoagulation. I think we've all recognized how much clotting has a role within ACS, and then certainly I think for longer term kind of outcomes of our adult sickle cell patients. And so having this done in such a fashion, it almost feels like, gosh, why did it take so long to kind of get something like this? But it's great to see. I think the one question I would have, Armand, too, in terms of both for future work or current practice, is there any interest in looking at anticoagulation, or do you not have knowledge of previous work for just vaso-occlusive events in general and preventing development of ACS, or just improving pain scores and narcotic use? I haven't seen that you had put a CARI at all, and I couldn't tell if that was ACS related, if that was just VOEs in general, but would be really curious about your thoughts there. I think the other kind of line that just piques my interest a little is thinking about variant patients, and particularly SC patients, and a little bit of a higher hazard ratio, certainly for that population, very small numbers. I just kind of am curious about that population in terms of having higher incidence of fat embolism being part of the pathophysiology. Is that a population that, because our included population was the relatively not sick, if you have someone who is SC and is just really quite sick, is with multi-organ failure, or probably maybe not quite to that degree, because then we'll get into contraindications, but is that a population you treat differently or think about differently in terms of your management and in putting them on the tinzaparin up front?
Thank you very much for these questions. So the first question about the use of therapeutic anticoagulation for the prophylaxis, if I understood well, is very interesting. But here also, I think the key point will be the benefit-risk ratio. So we are working on it, and we still have to do a lot of preliminary work, because we want to select patients with a very high rate of relapse. For example, you know that in emergency departments, when you look at the total number of hospitalization for vaso-occlusive crisis, in some centers, 1/3 of them is due to like 5% of patients. So those relapsers, if I can call them like that, may be a good population where a preventive therapy with possible side effects could be reasonable to test with this hypothesis. But we still need to work on this selection. Concerning the SC, in our practice, we really see that they are more prone to thrombosis. In the PATAC score, in fact, the SC genotype was associated with thrombosis in univariable analysis. In multivariable analysis, it was not there, but because higher baseline hemoglobin was in the model and more strong in the model. So the implication we have now is that we do a CT scan to all those having ACS, but it doesn't translate into immediate therapeutic anticoagulation before the study. And now the therapeutic anticoagulation is applied to everyone. Once again, we didn't have enough power to detect maybe some subgroup subtleties. The only thing we can have is the interaction, and there is no interaction between the genotype and the effect of treatment. So if you want to apply the treatment at this moment, we do it to everyone.
Okay, thank you. So at this point, we'd like to call our pediatric hematology colleagues to maybe ask some questions and maybe start to think about, like, as you mentioned, Dr. Dessap, this is like much more difficult to apply to children, but maybe the adolescents or young adults that we take care of, it might have some value for. So can I start with Dr. Z? And then I'll ask Dr. Willen to give their comments and questions.
Yeah, thank you for for sharing your slides. I thought this was a really interesting study, and very naturally being in the peds world was starting to think about how this could be applied to our patient population. I will say I think there, as you mentioned in the study, thinking about the pathophysiology of acute chest syndrome that we see in kids, I do wonder how much can be applied right now in this moment, although there may be opportunities to explore other kind of study design in the future. I think particularly in the younger kids, we think a lot more about infections like those atypical bacteria, and antibiotic therapy is a big mainstay of how we support these kids when they come in. Although, again, if you think about our adolescents and some of the young adults that are still followed in the pediatric world, there may be applications there. I will say, I mean, just thinking about the study itself, I was looking at the primary endpoint, and I do appreciate that there was statistical, it was statistically different at the time to resolution of acute chest as it was defined, although, it looked like really that was a change of maybe a day. And so I did feel like, I don't know if that's clinically significant enough to make me feel like I would change practice for myself. But I'm just curious to get people's thoughts on that. I do think the change in total morphine dosing was quite compelling to see, although that may be beyond, kind of alluding to that Corey paper. There may be other applications of the enoxaparin in that context. Yeah, I think those are
Okay.
some of the thoughts I had.
So concerning the application to children, yes, I think maybe the first extrapolation we can do is only the adolescents, because I'm not pediatrician, but I don't think you even do prophylaxis to very young children, only adolescents. So that could be a setting where maybe if a patient in an adolescent has a huge pulmonary hypertension during ACS, to have that in mind, that this is one axis of the pathophysiology that could be explored in those adolescents. The second thing about the difference in time to resolution, it's 1.5 days. We want to talk about days. So some physician may say, okay, 1.5 days is not important, but it's on an average of 6 days. So it's 1/4. So I think it's significant, and there is no translation in terms of going out of the hospital because of all the limitations we previously discussed. But the other thing is having 1.5 days of pain, or having a reduction of nearly half of the morphine I need. I think that's significant, and I think many physicians are used to the fact that these patients are painful. We know that the pain is extreme, very close to a bone pain, in case of fracture. And I think we are too much used to that now, and we consider that because we have morphine, it's okay. But from a patient point of view, I'm not sure of that. I think the less the pain, the better it's for the patient.
Yes, thank you. Shaina, Dr. Willen, did you want to give your comments and ask some questions?
Yes, I would. So I do also want to kind of reiterate what some of my colleagues have said, in that this study is wonderful, and I so appreciate you coming and sharing it, and it's just completely addresses an unmet need. I think we're kind of talking about application and different populations and generalizability, but there's no prior effective acute ACS treatment. So in that regard, like, this is really remarkable, and I just agree with my colleagues that this is super important to discuss. From a pediatrician standpoint, I completely agree with what everybody's saying, that there's absolutely a difference in pathophysiology, but I think where I am sort of struggling is where that cutoff is. So what age? What age? I think as pediatricians, as we've been discussing, we do take care of patients up to early 20s, and so do we really need to be thinking of an 18-year-old significantly different? Is it 15? Is it 20? And so I think that's where I've been struggling, but what this study and what this paper has done for me and my practice is really revisit that prophylaxis age. And I think Dr. Klings put this in the chat as well, but I think that highlighting the benefit of even just prophylactic dosing and just reminding ourselves as the pediatricians that this still is a vascular disease is a really important thing. So I think that was one thing that we really tried to do, is that it shouldn't be that you get DVT prophylaxis if you go to the adult ER, but you don't get it if you're in the peds ER. It really should be the age of the patient, and so it needs to really be more like cohesive in how we're treating our patients on the peds and adult side. And I guess I'm curious, I mean, I think we could argue from your study that 18 is the cutoff, but I'm also just curious of my pediatric colleagues of what age we think that is. I kind of proposed to my hematology colleagues that maybe even 15, we should be talking and considering other risk factors. And is this a patient, or are there other things that we should be thinking about that kind of play into that decision of who should be getting prophylaxis? And then also preparing our patients, because if you didn't get it during one admission, as you mentioned, a lot of our patients are frequently admitted with these issues. And so if they didn't get it during one and all of a sudden we're suggesting it in another, of having really good reasoning behind it, and kind of the kind of how we're going to sell it as the take home. So I'm just curious, do you think 18, I guess, is the place to start? Is that the right age?
As an adult, we chose 18 because that's official age in France.
Sure.
To do a study in an adult, because if not, you don't get the consent. But in our ICU, we usually take care of patients from 15. So, and physiologically, my impression, but it's subjective, is that those patients at the age of 15 are not very different from those at 18. So I fully agree that probably it should at least stimulate the questioning about prophylaxis, etc.
And so, Dr. Benjamin Kopp, that you want to give your comments and perspectives as a pediatric pulmonologist in all this?
Sure. Thank you so much. Yeah, I'm last on this, so all the good questions were asked already. But no, I really appreciate this study, and really the work of studies that you've done over your career so far and contributing. So it's really fascinating to see this all in one place. I would kind of posit that maybe 15 and up is reasonable, especially based on the cooperative study data with VTE. They had 15 and up and showing that incidence. So I think it's something that we need to think a lot more about in pediatrics. I guess my question goes to how we continue to better endophenotype people with ACS. Your algorithm really at the end is starting to get at that. If you're not identifying a factor for ACS and then going to CT, but do we need to be including more broad markers in that? How do we subphenotype better? And I wonder if you had thoughts on how we can do a better job of that.
Yes, this is really a key question, because ACS, as the name says, is a syndrome, not a disease. So it's really important to detect the main actor or the main actors in a given patient. And to date, the tools are very limited. So we saw that there is fat embolism, but if you want to diagnose this correctly, you need some induced sputum, which is not easy, especially in painful children, and then you need a specific coloration, etc. So we worked on the continuum between bone marrow necrosis and fat embolism syndrome, and we are publishing a nomogram based on very simple biological markers like LDH, etc., platelets, which are in the spectrum of bone marrow necrosis, to help probably identify those patients with fat embolism without needing special correlation or an MRI. And for the thrombosis, I think the PATA score has major limitations. The ROC curve was only 0.8, but the good news is that it's better than the revised Geneva score. So we have also here a tool to detect patients with macrovascular thrombosis within the lung vasculature. And for the last actor, which is infection, there have been major progresses in terms of nasal swab with PCR. So I think it's much better than 30 years ago today to do that, but we lack a large cohort with all those phenotyping to see the overlap, to see the differences between the children and the adults, and to see what is the main pathophysiology, depending, for example, on the age on which we should focus.
Thank you.
I see a few questions in the chat, so I'm going to turn over the floor to my co-moderator, Annie Coates, so that she can proceed with those.
Great. Thanks, Dr. Santiago. So it looks like our own Matt St. Ange asked, it looks like need for NSAIDs, so non-steroidal anti-inflammatory drugs, were an exclusion to randomization. Do you use just prophylactic tinzaparin for those patients requiring NSAIDs or no anticoagulation?
So there was no NSAIDs in patients in the study. The idea was here also to minimize the risk of hemorrhage. And in our centers, we don't use a lot of NSAID since the randomized trial where we showed that there was no global reduction in the morphine dose with NSAID. So it's really a case-by-case discussion for NSAID, but for this study, there was no NSAID.
Great, thank you, Dr. Dessap. And then there were a number of comments, some of which have already been emphasized in the discussion. Dr. Klings mentioned, so I think adolescent DVT prophylaxis is important, which sounds like many people are agreeing with. She also mentioned it is incredibly rare in our data of 400 adults to have DVT PE in kids under 15. She mentioned that we do have one case and it was provoked. Then Clarissa Johnson mentioned that she had an 11-year-old with hemoglobin SC developed DVT when admitted for a pain episode, not otherwise provoked, and thrombophilia workup was negative. So it can definitely have some outliers. And then Dr. Kopp did have another question. Unless there are any other questions from other audience participants at this point. Not seeing or hearing any. Dr. Kopp's question is, the cohort had a lot of abnormal oscillatory sounds, but limited cough. Could you speak to this phenotype?
Yes, this is typical. When I read the pediatrician literature, I find that there is too much cough, too much wheezing. So I'm not a pediatrician, but I really think that the bronchial presentation of acute chest syndrome is really rare in the adults, but it seems to be more frequent in the pediatric. And maybe we come again on the etiology, maybe more infections, maybe more viruses, etc.
Size of airway, probably, as well as a factor. Yeah, thinking as a pediatric pulmonologist.
Can I ask a question to the other panelists? I think if you guys all have now, at this point in the US, no tinzaparin, an 18 or 19-year-old that you're taking care of in peds or adult who is, on a couple liters of oxygen with ACS after admission for a VOE, like how many are putting that patient at this point on treatment, enoxaparin, or kind of what we have as equivalent? I don't know. I can't tell you. I've been, I haven't had any service time, since this article has come out in ICU or otherwise. I mean, I think I sort of feel inclined to with low bleeding risk, and I have a patient who very much meets criteria. I think one thing that kind of will potentially get me worried is like the patients that we just sort of say, okay, well, we don't need to do a CTA chest maybe because we're going to put them on therapeutic anticoagulation anyway for 7 days, but not really address that they have macrovascular kind of operate outside of the inclusion criteria. But I don't know. I'm intrigued. I sort of feel like with low bleeding risk, even though tinzaparin and enoxaparin are not the same, I'm a little bit, inclined, I think, after these data are, presented to sort of do that 7 days. But I don't know if I'm in the minority here of the panelists.
I don't think you're in the minority. I'm pulled in a similar direction. I think my hesitation is really what, like Dr. Dessap was saying, is like, is there some mechanism of the tinzaparin that is making it uniquely functioning in this way that is like leading to the improvement? If we had tinzaparin, I think it would be an easier argument. And so I don't know. And with the pace of studies in our field of sickle cell, I worry that if we're waiting around for the enoxaparin study, we're going to be behind the ball. So I agree. I have a similar struggle. I've not changed my practice today, but like I agree, like it's definitely worth the discussion and consideration.
Maybe I can comment on the fact
Please.
of replacing the CT scan by the short-term anticoagulation. I'm not sure the two things are similar. In fact, I think they are separate. The CT scan is there to decide whether or not I will do 3 months anticoagulations. So I think it's important to do it if you think there is a high clinical probability of macrovascular lung thrombosis. Because if you don't do it and you just do 7 days, we don't have data to know whether it's sufficient for a patient with thrombosis of large elastic arteries. We just anticoagulate them, and we never did sequential CT scan to see whether a shorter course is sufficient.
Yeah, that is definitely my fear too. Of just, I think it's like, oh, well, if this is now the pathway, then we just need to anticoagulate them and we don't need to do the CTA. But I think having the CTA and the rollout of the macrovascular is like really important. Whether that is guided for everybody as standard of care, whether that's guided by PAT ACS scoring. But I think, I don't know if it will become an issue if this is more further adopted for at least my hospital. But
so for me, this study is not practice changing, and for a couple of reasons. So first of all, the American Society of Hematology guidelines that were published in 2019 recommend that after someone's had a first-time venous thromboembolism in the context of sickle cell disease, a known hypercoagulable state, that they go on lifelong anticoagulation. We know that from our data that 19% of our adults have had a prior venous thromboembolism, so they are already on therapeutic anticoagulation. The other piece is that I would want to know by CT-piegram if there is an acute PE. And the reason why lifelong anticoagulation is recommended is from Ted Woon, also from UC Davis, where Willen is at, published data to suggest that the 5-year recurrence rate after a venous thromboembolism in someone with sickle cell disease is about 24%, which is exceedingly high. And that was the recommendation that led to the recommendation for lifelong anticoagulation. My concern when I sort of think about this study in the context of my population or our population of patients is that I'm not sure the trial is applicable and to the entire spectrum of acute chest. And that's why I don't think it's practice changing yet. I think it's a very provocative study. I agree with the biology, and so I may shift. And but I think we're also and so I think we do have a very low threshold for using therapeutic anticoagulation in our adults with sickle cell disease during their hospitalization. So I think there is I may shift on this with time, but this is, and I agree with you, Shay, that it's unlikely that a similar study is going to be completed in the United States or in any other country. So I think it was a mammoth effort to conduct this study, Armand, and I think it is incredibly provocative in terms of whether or not this is really attacking some of the pathobiology of acute chest, and it really is where this umbrella term of acute chest syndrome once again falls short. And because so many of our adults with acute chest have actually acute decompensated congestive heart failure, and related to diastolic dysfunction of their left ventricle, and that is also under the umbrella of the non-coughing ACS patient.
Mm-hmm. And so many of our pediatric patients have asthma exacerbation or something, or an infection. Yeah, and it's still called the same thing, which is very problematic.
I couldn't agree more. Unless there are any burning additional comments or questions, since we're just past the top of the hour, on behalf of the ATS Pediatric Assembly Journal Club and Web Committee, I want to thank Dr. Dessap for your fantastic presentation, for our incredible panelists, for the lively discussion, which I think is such a strength of this format, that we can have these kind of interactive discussion and learn from each other. And I can certainly say I've learned a lot today. So thank you all for your involvement, for our audience participants too. And just a reminder that if you registered, or to tell your colleagues if they registered for the Journal Club but weren't able to attend in real time, they will be able to view that. The recording is typically up on the ATS website in about a week, and you'll automatically get that recording. So please disseminate widely. But thank you all, and hope you have a wonderful rest of your Friday.